Hi, this is Ed Crowe. Thanks for attending. Today, we're going to talk about how we can figure out the $2,000 Medicare Part D drug cap. So we're going to go over that today. Going to talk about the 2025 RX MOOP and why it was created, how it was created, what is supposed to count towards the $2,000 drug cap. That'll be the interesting part of this webinar. Talk about why the math doesn't work, because just to get ahead of it a bit here, the math doesn't work in most cases. The strategy as an agent you want to use, explaining it to clients, and then talking about using a quote site to quote this and see that the math doesn't always work, and talk about non-commission plans as well. So first of all, we'll start with the cap and how it was created. So the Part D drug cap was created by the Inflation Reduction Act, IRA, and it applies to all plans. So that can be standalone Part D plans or Medicare Advantage plans with, MAPDs, Advantage plans with drug plans in them. Anything effective 1/1/2025 and later. So for this AEP, obviously, which is all 1/1/2025 effective dates, it applies to those. First of all, the donut hole is most of you know, is removed. So there is no donut hole, and when you go into the catastrophic phase, there's no cost. So there technically is no catastrophic phase anymore, but regardless, there is no cost in that phase. For 2025, however, there will still be a deductible phase. That deductible is going to be a max of $590. That doesn't mean that the standalone drug plans or the Advantage plans will have a $590 deductible. That just means that's the most they can have for 2025. After the deductible phase, then you go into the initial coverage phase, or copay phase as we want to call it. And in that phase, the client can pay copays, or it could be a percentage cost share as well, up to 25%. Is the actuarial equivalent of that cost share. The actual percentage that they pay towards the drug can be more than that, but you'll have to look at the plans to see the tiering. But it either could be a copay or it could be a co-insurance. Then the big benefit, so to speak, is that the member for 2025 is capped at $2,000 out-of-pocket costs for the year. So whether they have a deductible on their plan or not, then they go into the copay phase, whether they're paying copays or co-insurance. Regardless, once they get to $2,000 out of their pocket, they are covered in full for the rest of the year. There is no catastrophic level with cost sharing at that point. So the tricky question is, what counts towards the $2,000 RX MOOP in 2025? Well, we can look at what is written that counts, and we'll go over that. So any member drug cost share, including deductible, copays, and co-insurance. So in other words, anything coming out of their pocket towards drug costs counts. Now, if there's a payment made on the member's behalf, that also would count. So I always wondered about that statement. When I was looking at it, it always said in the language, anything paid on their behalf counts. So that would be things such as SPAP, State Pharmaceutical Assistance Plans, LIS, which is extra help, donations from charities towards the cost would count towards that $2,000 cap. Also, any payments that they make through the new MP3, the Medicare Prescription Payment Plan, would count. And for those not familiar, the MP3 is if a member has substantial costs for drugs, they can go to the pharmacy and get those costs spread out over 12 months. I've done webinars on that in the past. I'm not going to dwell on that topic, but any payments made through that program would count towards the $2,000 as well. So what doesn't count? So their Medicare Part D premium, whether it's a standalone plan or the premium associated with an Advantage plan. So if an Advantage plan, for example, had a $50 premium and the carrier had deemed that 15 or 20 of that a month was drug premium, regardless, it won't count. So premiums do not count towards the $2,000. The big one is non-formulary medications. They do not count. And you'll see that often where a client will have a drug plan and you might run it on Connecture, Sunfire, or one of the carrier portals and see that they're paying more than $2,000. And usually the reason for that is because they got a non-formulary med in there. And that's a chicken and egg thing as well, because as most of you probably are aware, they can't get a determination on if they'll be given a non-formulary exception until they enroll in the plan. So you can't do it ahead of time. You can't say, well, I got somebody who's interested in looking at a UHC standalone drug plan. I want to see if they can get a formulary exception for this drug they take. None of the carriers will give that to you until they're actually enrolled. Continuing, what doesn't count. So what doesn't count are drugs that are not covered by Part D. And that means things like Part B drugs, which is important. A Part B drug in most cases is a drug that is given to the patient or client at a medical facility, usually something through an IV. And it goes under Part B if they have that drug waiting for them at the facility, and if they somehow put that drug into the person, it's going to be a Part B drug. And Part B drugs are not covered, are not part of the $2,000 cap, I should say. Drugs purchased OTC and drugs purchased out of the country, such as through a Canadian pharmacy, do not count towards the cap. What also doesn't count, to make it a little confusing, are non-qualified payments made on the member's behalf. So we talked about payments made on their behalf count, but it depends on who it's made on their behalf from. So group health plan payments for workers or retirees do not count. Payments made by Medicaid, and I know that sounds tricky, but that is straight Medicaid, Title 19. So usually when people have Medicaid, they also have extra help. So that isn't applicable. If they have a SPAP plan or extra help, that will count towards the $2,000 cap. But if somebody's just on Medicaid, that will not count. VA benefit payments through the VA or through TRICARE do not count. Liability, no fault insurance, and workers' comp doesn't count, and manufacturer discounts do not count towards the cap. So great, we're all set. Should be easy then to determine how much somebody will pay out for the year and why. It's easy to determine how much they will pay because you can run it again on Connecture, run it on Sunfire, run it on one of the carrier portals, and you'll see how much out of pocket they'll have. Now, explaining to them why is a little different story, and there's a lot of inconsistencies here that we just got to talk around as agents. So if you want to use some examples of what I'm talking about, for example, you can run on a number of the standalone drug plans or advantage plans. You can give the person one drug. In this case, let's say you give them Eliquis. And let's say we put them on a plan without a deductible and without co-insurance. So Eliquis is $47 a monthly copay on that plan. Well, when you run it, you'll see that that person, no deductible, taking Eliquis, paying $47 a month for it, they will show as hitting the 2K in December. How does that math work? The drug is $47 a month. That's what they're paying. It's coming out of their pocket. Times 11 months is $517, well short of the $2,000, yet they'll be hitting the cap. Now, that's great, but it's going to be difficult to explain that, and you're just going to have to say to them, nobody really knows. The answer is, it's just, you've met it, so let's not complain about it. You're going to pay $517 out of your pocket. Some people will show more than 2K out of pocket when you run these. Almost always, that is because out of the drugs you put in there for them, one of them is non-formulary. And if it's non-formulary drugs do not count towards the $2,000, and that's why they will come in over $2,000. And again, that gets us to the whole formulary exception thing. It's a chicken and egg problem. They got to be enrolled in the plan before they can apply for an exception. So what's my suggestions with this? Well, run the plans. Don't guess on the drug plans. I know I talk to a lot of agents and agencies, and sometimes they'll eyeball this and just enroll them in a standalone drug plan or an advantage plan that looks like it has the lowest copays, or maybe all their drugs are in the formulary. Those days really are gone. If you continue to do that, it's going to put you in jeopardy because it's really impossible to understand the out-of-pocket without running them. So again, run Connecture, Sunfire, carrier portals. Some people I know through Integrity use Medicare Center. That's actually just Sunfire behind the scenes, whatever. It all works. But you need to run it and see the results to see what is going to be the lowest out-of-pocket for your client. And then explaining again why they have one drug and they're hitting the cap only after $517. Good problem to have, but as far as an explanation, again, you just say to them, not really sure, but this is obviously has the lowest out-of-pocket for you. And then the people that have more than 2,000, usually the answer is because they have a non-formulary drug. On Connecture, Sunfire, we have the whole issue of plans that are standalone drug plans, especially, that are no longer commissionable. So both of those systems are going to have the show all plans button. And you got to keep that in mind when you run it. So it's going to show you, if you want to see the non-commissioned plans, when you run this, they won't show up initially. If you click the show all plans button, they will, and that's companies such as WellCare. So you can see when you click the show all plans button and WellCare shows up, the reason it wasn't on there is, one, maybe you're not certified to sell it, but the main reason will be because it's a non-commissional suppressed plan. So just know that when you click that button and it shows it, you know, if you sell that plan, you're not going to get commission for it. At the end of the day, when you're talking to people, the results are the results. You can show them, run the plans, show them the lowest out-of-pocket options, show them what plan comes out the best for them. Remember, you didn't make the rules. CMS did. They put in this $2,000 drug cap. I know it was a thing that everybody talked about and they were very happy about. But the reality is it benefits, the $2,000 cap benefits 9% of clients, about 9%. And unfortunately, when you do that, the rest of the people are going to pay for it. So you're going to get, you know, people that have Advantage plans, as you know, have been watered down. Part D drug plans, the cost has gone up. A lot more co-insurance on tiers 3 and 4 now. You didn't make the rules. All you can do is put them in the best plan possible. In a year like this year during AEP, you're going to get a lot more people shopping plans as a result, a lot more of your existing clients especially. I would strongly suggest to utilize something like Retire Flow and Connecture or Blaze Connect on Sunfire. It'll make you be more efficient. If you're not familiar with either of those systems, I've done a webinar on that in the last month or so. It's just a way to capture their information, have it automatically integrated into the client's profile on either system. And it really is a lot more efficient from a time standpoint. And it also can protect you from things like a client gives you a list of 5 drugs, you run them, show them the plan that comes out the best. Then you get a complaint because the client says you didn't tell them how much a certain drug would cost. Well, turns out they didn't give you that drug. Well, when a complaint comes in, it's hard for you to prove that. But if you've used Retire Flow or used Blaze Connect, it'll be easy then because you have proof, it's time stamped. You can say, well, they didn't send me that drug, and here's the report of what they sent me. So as you can see, they omitted that drug, so there's no way I would have known. And you really do that to protect yourself. And that's it. Quick webinar. I'm done. You can watch our videos on YouTube, youtube.com/@Crowe Medicare. All the topics I've talked about here, the things maybe I've mentioned that you aren't familiar with. Again, just go back to our channel and look. We've done webinars on all of them, and it should help answer your questions for you. Other than that, I appreciate you coming on today, and thank you.